Well, welcome everybody. Thank you very much for attending this very interesting session. My name is Carl Leroux. I'm a clinician scientist from University College Dublin, and I'm going to ask the co-moderators to introduce themselves. Dimitri.
Dimitri Benaras, bariatric surgeon in Bristol, UK.
I'm Rosario Pivonello. I'm replacing actually my chief, Anna Maria Colau, from Federico II University of Naples.
So this is an interesting session that we've been asked to put together, really talking about this idea about is it surgery against medicine or is it surgery with medicine? And we are going to present some of the randomized controlled trial data in this space. And I'm going to ask Dimitri to introduce the next speaker.
It's a great pleasure to introduce Alex Miras. I think most of you know him. He's based in also on the island of Ireland, but he's in Northern Ireland now. Alex, looking forward to your talk.
Yeah, thank you very much for the invitation. Thank you all for attending. Yeah, so I've been asked to talk to you about one of the trials we conducted in the past. And the main reason being that it was the first randomized controlled clinical trial in this field. And I just want to make it clear from the beginning that the main aim of this trial was weight loss, additional weight loss with medications after surgery. We just happened to be doing it in people with type 2 diabetes and obesity, and I will explain why. These are my conflicts of interest. So this is one of my favorite slides from 2023. It is an excellent, really good review in the Lancet by a number of speakers in this meeting, including Paulina Salminen and Ricardo Cohen, etc. And what you're going to see here is this beautiful variability in the response that we see after any of the treatments that we have for obesity, including bariatric surgery. I always find it intriguing, disappointing, but intriguing, why some people, even after the gastric bypass, don't lose any weight whatsoever, or they regain it after some time, and how a small proportion of people manage to achieve very significant weight losses, even with relatively modest lifestyle interventions in terms of severity. So what is suboptimal weight loss after surgery? It all depends on how you want to define it. And tomorrow you will be good, and we would welcome you in the session where we are presenting the IFSO guidelines on a number of topics, including this one. I can tell you it took us hours of debate to decide what is suboptimal weight loss after surgery, because these are, of course, lines in the sand. We ended up at around 15% weight loss. So depending on how you define it, of course, you get a proportion of people who do not do very well. And very, very, very rough estimates suggest that this number is about 20% or so. Depends on the procedures, et cetera, I appreciate that. Again, I would like to really emphasize the two important messages, that when I give a patient a GLP-1 receptor agonist and they do not respond, I don't blame the patient and I don't blame the GLP-1, okay? And my GLP-1 is not better than my colleague's GLP-1. And I suggest you do the same with surgery, unless there is a major complication, of course. You've done perfectly good operations. There's nothing wrong with what you've done. I don't think anyone else can particularly necessarily do it better, and there is definitely nothing wrong that the patient is doing. Now, the poor weight loss, or suboptimal weight loss rather, after surgery is something that is very, very poorly understood. We understand a lot more about how surgery causes weight loss and glycemic remission, but we really don't understand the mechanisms of suboptimal response. There are some suggestions from a couple of studies. One of them Carl did some years ago now. There are some suggestions that people with suboptimal weight loss have reduced gut hormone responses after surgery. This has been replicated in another study from Copenhagen, again suggesting that there's nothing much different between good and bad responders in terms of energy expenditure, a number of other hormones. It appears these anorexigenic and incretin hormones may be reduced in those people who don't do as well. Of course, we don't know if that is the cause, but this is an association. So a number of years now, in 2014, almost 10 years ago, is when we started thinking about this study, in which what we wanted to do is we wanted to ask the research question of if we can make up this gap between good and suboptimal responders, this gap in GLP-1, if we could make it up with medications, can we bring the responses of the suboptimal responders up to those of the good responders? So we embarked on this randomized controlled clinical trial. 80 people were randomized to liraglutide, 1.8 milligrams. This is the dose you remember for diabetes. This is not Saxenda. And they were randomized, so 80 patients were randomized on a 2-to-1 ratio. So 2/3 of the patients had the medication, the other third had placebo, and it was double-blinded. Now, these were people that had diabetes before surgery and obesity, of course. And the way that they were eligible for the trial was that they did not have achieved remission after these operations. So these are the baseline characteristics. You're going to see a number of things. So first thing to say is that their duration of diabetes was quite long. So the fact that they had not achieved a remission should not necessarily be seen as a surprise, but that's what we had to do at the time because Saxenda was not available then in order to conduct the study. We had to take people with diabetes and we had to find an eligibility criterion which was glucose related. The other thing that you will see is that the weight loss that they had achieved towards the bottom of the screen there after their operation was about 20%. And I should have said that these are people that had either bypasses or sleeves, yes, no bands. So the 20% weight loss after a number of years after surgery is not necessarily a bad result. There were some suboptimal responders, but overall I wouldn't say that the group average was that bad, okay? So these are the main results. In the red line, you have got liraglutide, 1.8 milligrams. In the blue line, you had placebo. And you will see that the primary outcome, which was glycemic control with an HbA1c, you see pretty much stability in the placebo group, maybe a bit of a rise. But I would like you to focus your attention on the liraglutide results. So you are seeing a reduction in HbA1c, which is about 11 millimoles per mole. In all money, that is about 1.1 or so percentage in HbA1c. And you also see a weight loss, which is 6% at 6 months after intervention. So you may, if you have looked, or if you remember the literature of using liraglutide on its own for diabetes, in people who have never been operated, you're going to see almost the same results. So it appears that by adding a medication to surgery, the medication works equally well as if it has been given in someone who has never been operated. And the effects that you are seeing at 6 months are at worst additive. So you take the operation, you add the medication, equals X, as simple as that. An even better scenario is that the effects are synergistic. So we get more of what we would expect by each individual part of the equation. So that creates a number of very exciting questions. Why would there be an additive effect. We were not necessarily expecting that. We also see always a variation in response, even in those people that we treated after surgery with a medication. So you'll see there some people gain weight with liraglutide. Some people lost extremely large amounts of weight, 20% of weight loss with liraglutide after surgery. Okay? This is the normal variability that I showed to you earlier on. The good news is that, when I have results like that, I always wonder whether they are true or not. So that has always been something that has been in my mind for a number of years. But I am pleased to now report that Rachel Badaram's group at UCL has done a very, very similar study in which they use Saxenda, so 3 milligrams of liraglutide in people with obesity. I don't think they had diabetes. I think diabetes was an exclusion criterion. And look what they found. At 6 months of treatment, exactly the same time point as ours, they found a weight loss of about 8%, if not a little bit more, which is exactly what you would expect with liraglutide in people who have not been operated. So now we have got 2 randomized clinical control trials in the field, one in people with diabetes and one without, which are showing very, very similar results. So to end this presentation, I would say that the fact that the results are additive at worst is very exciting because it creates a number of mechanistic questions. In terms of our patients, it is even more exciting because it suggests that if we combine surgery with medications, certainly with the newer ones, we can get some very impressive results, to the point that for some of our patients, we might be able to achieve a remission of obesity or a normal body mass index, which is something that we were not expecting for a very long time. Studying the mechanisms of suboptimal results after surgery remains critical. It may not be very sexy at the moment because all of the medications that have come out, but it is really, really important because surgery is still the most effective treatment, and also because we're going to see similar suboptimal responses after the medications. So we need to have a template upon to work on. And the reason why these mechanisms are important as well is that because if we understand them and if we understand why the particular patient, the specific patient in front of us, has not responded to an operation for a specific reason, then we can target that reason with the appropriate treatment, whatever that treatment may be. Thank you for listening.
I would like to invite anybody that would like to ask questions, please to come to the microphone. So please, make a start. If you introduce yourself, just say where you're from, please.
Surendra Ugale from India. Very nice presentation, Alex. Question for you is, have you ever encountered a situation where the patient didn't lose weight, but you achieved a lowered HbA1c?
Repeat the question again.
That the patient didn't lose weight.
Did not lose weight.
Did not lose much weight.
Yes.
But had a good.
Yes, that's a very good question.
And how do you explain this
I
then?
explain that because that's for reasons that we don't understand. When you give, for example, a GLP-1 receptor agonist for people with diabetes that have never had an operation, you see exactly the same patterns. There are some people who lose weight, some people whose HbA1c improves only. There are people who achieve both, and there are people that do not achieve any of those. And that demonstrates, well, first of all, we don't understand why that happens, but we do see it. And it demonstrates that this link in our heads of weight and diabetes, which is too strong, perhaps, should become less strong, and we should be separating the two mechanisms.
Please.
Okay, Dag Hofse, Norway. You included both patients operated with bypass and sleeve gastrectomy.
Correct.
Was the effect the same in both groups?
Correct.
Okay, thank you.
Correct.
So, Alex, where does this leave us when we are thinking about patients, for example, that don't respond, that have an option between a reoperation and a medication? So, you as an internal medicine doctor, how do you counsel a patient that says, doctor, should I have a reoperation or should I try the medication first?
Yeah, it depends, and that can be my answer can be controversial. And remember, I'm a big fan of surgery, but I am not a big fan of revision surgery. And it's also important to understand what does revision surgery mean. So if you're, in my humble opinion, yes, convert a band to a sleeve or a band to a bypass. That is, I think, reasonable. But beyond that, I am not sure that making any other conversions, I know people would disagree with that, is necessarily a good balance between efficacy and safety. So if someone has got a sleeve, if someone has got a bypass, I would not be keen on a reoperation unless there's something seriously wrong or something you can easily fix. And actually, I would be biased more towards medications. Now, let me also clarify the importance of an important point about medications in this study and in general. Yes, we do not know the long-term effects of these medications in terms of, not effects, rather safety, okay? We don't know them. We have got data up to 4 years. The data up to 4 years now looks very, very promising. So I would be surprised if we see anything we haven't seen before. And also don't forget that we have been using these doses and these medications for diabetes for the last 17 years, and we haven't seen anything that is terrible, apart from the things that we already know when it comes to gallstones, pancreatitis.
Okay, question?
Great presentation, thank you. Dilhana Badruddin, Mayo Clinic, Florida. I'm taking into consideration the fact that we can't predict which patients are going to regain weight or which patients will be suboptimal responders.
Yes.
Should we start all patients on medications, and if yes, then what's the timing?
Oh, yeah, that's a very good question, and I would say no. Because then, if you start the medication too early, you don't know what's working and what isn't working. It's always good to know what is and what isn't working, and waiting for a year, because then you can decide. Certainly, you can decide what is working, what's not. Is not exactly a disaster, right? So I would wait for a year. That would be my minimum time point before I intervene with medications. Some people may want to do it sooner, and I can understand. The only group of people that I would continue GLP-1 receptor agonists and SGLT2 inhibitors are those people with diabetes and cardiovascular or renal disease, and I would do that automatically. I wouldn't wait for the 1 year. By the way, with no evidence whatsoever. I just think that sounds right.
Yeah,
Last
Alex,
question.
You mentioned that the good responders had high levels of GLP-1.
No.
They didn't.
Well, we haven't measured it in this study. Oh, sorry, in the study that I have shown you, this specific study, we haven't studied it. But yes, in the data from 2 studies so far, that seems to be the case.
So would physicians maybe in future then consider that they'd measure these levels if the levels are poor, not recommend surgery for such patients? Would that be a situation?
Again, there are many unknowns. We haven't shown that these levels are responsible, or lower levels are responsible for the suboptimal weight loss. We have just shown an association. But I think that considering the people that we studied had lost 20% of their weight after their original operations, I would not necessarily consider them suboptimal responders. So I'm guessing that their GLP-1 levels are probably okay, which tells us that if you add GLP-1, even in people with already good GLP-1s, you still get an effect, which is very interesting.
Well, thank you very much, Alex. I'm now inviting Phil Schauer to please come to the audience. Phil has really revolutionized our field by doing the Stampede study. That is still, it's like the gift that keeps on giving. So we can learn from it, and the way it was conducted really was the way that we have modeled all future bariatric surgery randomized controls trials on. So Phil, over to you. Please keep to 10 minutes so we have plenty of time for discussion, please.
Absolutely. Good afternoon. It's great to be here. And I've been tasked with the challenge of discussing this concept, which is not a new concept, after all, of adding medications to surgery in suboptimal glycemic control to achieve optimal control. And this was actually the design of the Stampede trial. First, let me just, what is the opposite of adding drugs to surgery? The opposite of that is achieving full remission. And many of you are very familiar with this landmark publication of Professor Walter Porres back in 1995, was one of the first to show that a surgical intervention could actually lead to remission of diabetes. In those days, they called it resolution. In other words, achieving normal glycemia without medications, and we were all, alarmed by this and thought it was amazing. My own early work, this is 2002, is essentially a duplication of the Porres paper, although my study, and this was back in Pittsburgh, was laparoscopic gastric bypass, whereas Walter Porres was open gastric bypass, and lo and behold, we found a similar 83% remission. And from that point forward, everybody, particularly the surgical community, thought that 80% of people who have bariatric surgery with diabetes are going to get remission. We subsequently realized that is not the case. There are a couple factors you have to consider. One is the type of patient you're operating on. It turns out that in our study at Pittsburgh and Porres' study, these were patients who were seeking bariatric surgery, and most of them had early mild diabetes with fairly good beta cell function. So that's a factor. And then secondly, these early reports reported 1-2 year outcomes, okay? We later found, and this was after I left to go to Cleveland, we followed our patients who had bariatric surgery, 3 different types shown here: gastric bypass, sleeve gastrectomy, and gastric banding. And these are patients who had at least 5-year follow-up, and we reported the short-term remission. And back in those days, we were using the terms complete remission, which is A1C of 6% or less without meds, or partial 6.5 or less without meds. Today, we just say if you reach less than 6.5 without meds, that's remission, okay? So you can see then, even with gastric bypass at 5 years, if you add both of those columns together, 30 plus 31, you get 60. So definitely less than the 83% we reported early on, and it was even less for sleeve gastrectomy. That was essentially 22 plus 9%, so about 30% for sleeve were in remission, and gastric banding was even less. So when you're looking at long-term remission, we have to come to the grips that not all patients will achieve that astounding result. Now, not that remission is desirable. Getting a patient to the point where they're not relying on any medication is quite desirable. The only practical way really of achieving that, honestly, is early surgical intervention, when patients have very early disease and they have very good beta cell function. Now, then came a slew of randomized controlled trials, and Stampede was one of the first. And it's a misnomer to say that these trials are surgery versus medicine, because what they actually are, bariatric surgery plus medicine versus medicine and lifestyle alone. Because in these surgical trials, all of them, patients are getting glucose-lowering agents as well as surgery. So let me just go through the design of the Stampede trial so you understand what I'm talking about. So patients were randomized into 3 groups. There was an intensive medical therapy, which included intensive lifestyle therapy according to the ADA guidelines, and drug treatment. Now, this trial started in 2006, so The drugs that were available during that time were a variety of oral agents, for example, TZDs and so forth, sulfonylureas. The GLP-1s, the oral ones were just becoming available, and insulin. And throughout the 5-year component of this trial, the newer drugs were added to some degree as they became available by the insurance providers. Okay, so the goal was our endocrinologists to drive the A1C to 6% using whatever medications, including insulin, that they could get to do that. Then the other groups were gastric bypass plus medications, sleeve gastrectomy plus medications. And our goal was to see how did things look 5 years later, okay? And let me just share with you first the baseline characteristics. And this is important in any trial, particularly understanding, the history of diabetes prior to surgery, how many medications the patients are on at baseline, how many patients are on insulin, because these are good markers of beta cell function. And if your trial includes patients with early disease, you're going to get a great response from surgery or any intervention. If they have more advanced disease like STAMPEDE, not all of these patients are going to end up with remission, okay? So you keep that in mind as you look at the results. And then this is the change in A1C over the 5-year period in the medical versus gastric bypass and sleeve gastrectomy. Now bear in mind, in the medical group, these patients were getting, the best medical therapy of the day. The injectable GLP-1s weren't available at the time, but many of them were getting oral GLP-1s, liraglutide, so forth, and TZDs and other agents, and of course insulin. And you can see at 5 years, most of the medical patients were no better off than they were 5 years before. There was initially a very strong response, but over 5 years, the A1C tended to creep back close to the baseline, whereas with surgery, the vast majority were significantly better off. And even with this group that had very advanced diabetes, about a third were in remission with gastric bypass, and about a quarter in remission with sleeve gastrectomy. But this is perhaps the most important slide for this particular topic, because we looked carefully at the diabetes medication usage in the 3 groups at the 5-year mark. For the medical group, it was at least the same, if not more medications than when they started 5 years before. With gastric bypass, 45%, so approaching half the patients were able to be weaned off all their diabetes medications. And sleeve gastrectomy, about half again, 25%, were on no medications. But notice, going back to this slide, that the A1C at 5 years for bypass and sleeve were about the same. So the patients who had sleeve gastrectomy achieved similar glycemic control. So how did they do it? Well, they did it by having more medications. You can see here a high use of the oral medications, a mixture of the variety of different classes of oral medications is what enabled those sleeve patients to achieve similar glycemic control than gastric bypass. And throughout the study, the newer agents were added as well. So I think that's an important message, and potentially, the sleeve gastrectomy plus medications could potentially equal a gastric bypass in terms of long-term glycemic control. The one main difference between the sleeve and the bypass was those that had bypass not only required fewer medications, but they delivered greater, they had greater weight loss than sleeve gastrectomy. That is undoubtedly probably one of the mechanisms of improved glycemic control, is just a reduction in excess adipose tissue, which we know improves insulin resistance, among other factors. Now, in addition to STAMPEDE, there are many other, at least 11 other randomized controlled trials that use a very similar methodology. These were surgery plus medications versus medications alone, with lifestyle intervention. comparing different procedures, gastric bypass, sleeve gastrectomy, gastric banding, and virtually all of them showed very similar results. There was just one exception. The study, third from the bottom, by Ding and others, just compared gastric banding to medications alone, and it did not show superiority of gastric banding over medications alone. But the rest of them certainly did. Now, in an effort to extend the follow-up, 4 of these randomized controlled trials came together, let me just summarize, to form the ARM study. And the data was actually published or presented a couple months ago at the American Diabetes Association and is under review right now. And we're going to have a much more precise look at medication usage in that particular trial. But the important point here is not necessarily these surrogate markers of disease, but the effect of these interventions, medicine and surgery, on long-term longevity, heart attack, stroke. And this is just one example of a major meta-analysis that shows that these operations, when they do deliver weight loss and improvement in glycemic control, result in reduced mortality. We should keep that in mind, that that is the end goal. So in summary, combining medications with surgery, Stampede and other randomized controlled trials have shown that can mitigate the variability of glycemic improvement with specific type of operations. And this is an important message, particularly for the endocrine community who are managing these patients on a day-to-day basis. Thank you very much.
Thank you very much. So we have some time for questions. If people will take some, come to the microphone. Please do come to the mic. But Phil, that was an amazing presentation, and it is actually the first time that it was articulated so clearly that these randomized controlled trials were trials of surgery plus medicine against medicine. And, in your own career, how have you seen that change? Because you were the first one to set up that study, and, that hemoglobin A1C, that's exactly the same after 5 years, is because the sleeve had more medicine. And initially, people thought that was a bad thing. And now we are seeing that these medications are helping surgery to achieve even better outcomes. So how has that changed in your career, if you give your perspective?
Well, when these first studies were coming out, it was competitive. Which one is better? Surgery or medicine? And at the time, surgery was trying to get some credibility, right, in the field. But the dialogue, fortunately, has changed. And that is, as opposed to this question of which one is better, medicine or surgery, because they are not mutually exclusive. Right. The question is, how can we get patients to good target, whatever that target is? A1C less than 6, less than 7. How can we, because we know from these large population studies, even today, a high percentage of patients living with type 2 diabetes are not at good glycemic control. So let's use whatever tools we have. And some patients are going to need a variety of different tools to achieve those targets. But the good news is we have powerful tools available today.
Please, thank you. Question.
Surendra Ugale again. So Phil, when you have a study that is so powerful from a premium institution as yours, why aren't the organizations who make the guidelines delinking BMI from this? Because you're clearly able to show so much of benefit, especially what you showed at the end with the mortality. And you really need 5 years of control on the glycemic variations to get that a really useful advantage. So why aren't institutions, or let's say the governing organizations, able to delink this to make it available to people who are suffering from diabetes, which ends up with that mortality?
Yeah, well, there has been progress. The ADA, for example, for the last 7 years, in their annual guidelines, includes recommendations for surgery with the BMI as low as 30 or even 27 for certain ethnic groups. The recommendation is not quite as strong as for the BMI of 35 and greater. And my understanding for that is their belief that the data, there's not as much data in that 30 to 35 group. However, all of those 12 randomized controlled trials included patients in that lower BMI group. And we found in Stampede and most of the other trials that the benefit in terms of glycemic improvement was just as good in the 30 to 35 BMI group as 35 to 40. So hopefully we are getting to that point to minimize the importance of the BMI in terms of the indication for diabetes treatment.
And so ADA, is it accepting your suggestion that we take remission at 6.5? Because in practice, that is what is clinically more relevant. And we've been sort of hardlined at 6 unnecessarily, I think.
About 2 years ago, the ADA got together a group of experts. And fortunately, there were a few surgeons on that panel, Francesca Rubino and myself, among like 10 other endocrinologists. So we did have a voice. And there was an agreement to simplify remission. Just make it simple. You know, the opposite of the diagnosis. The diagnosis, you have to have a 6.5 A1C or greater. So remission is if it's less than 6.5 without medications, that's remission. Yeah.
Thank you.
So Phil, may I push you on that? Because what you have shown is that your internal medicine colleagues did their absolute best and they threw the kitchen sink at your medical arm. So they threw not only a lot of different medications, but also high doses of medications.
Right.
But after surgery, although the medications may be used, the doses that's required is much lower. And of course, the poison is in the dose. So do you find that it's much easier to treat people after surgery with medications because you don't have to drive the dose so high?
Yeah, you get both. You tend to, they need less drugs. Even those that had sleeve gastrectomy required less drugs and lower dose. So understanding that the side effect profile is often driven by the dose, you may be able to add a variety of drugs at a lower dose without, those unwanted side effects, which are often, is what drive the problem in, patients dropping the drug is those side effects, particularly hypoglycemia and so forth.
Phil, that Stampede has really changed our thought process for a lot of us here. And you've demonstrated surgery, you've used surgery plus medications for diabetes, but I was wondering what your thoughts are on doing this for obesity now. So we'll be doing studies on surgery plus medications for obesity per se.
Absolutely, Dimitri. And I think, we need to come up with a term. Maybe we should call it remission of obesity. And maybe should that be 30? And if you can, after all, once you get below 30, there still may be some comorbidities, but most of them are improved or gone. So maybe we need to start thinking about, there's clearly been targets of therapy for diabetes, that's your A1C, but for obesity treatment, the target of therapy is, getting the BMI to 30, or maybe it's 25. And how you get there, it may be surgery plus meds, or it may be surgery alone, but having a definitive target, and maybe it's a certain BMI with or without comorbidity. But I think we should start thinking about target therapy.
So maybe a final question to you, Phil. So if I ask you to look into your crystal ball into the future, so how do you think we need to change the narrative, what we say to our colleagues, both surgical colleagues, but also internal medicine colleagues, about this concept, about is it surgery against medicine, is it surgery with medicine? How do we move the field forward? Because right now there's a lot of paranoia in the field, right? Mm-hmm. On both sides. And, so how do we fix this?
Yeah, let's collaborate, bring both groups together. There's some phenomenal tools, the medical, the surgical, and let's not forget lifestyle, that can be very effective. And, given the fact that the last statistic I saw from the NHANES data in the United States, only about 25% of all patients with type 2 diabetes are at all three targets of therapy. Right, glycemic control, lipids, and blood pressure. We got good drugs for lipids and blood pressure, so let's work together to get 80%, 90% of our patients with diabetes, at good glycemic control, and then we're going to see just phenomenal reductions in the mortality and morbidity of the disease.
Thank you very much.
Okay, and now it's a great pleasure to introduce Dr. Ricardo Cohen. He's the director of the Center for Obesity and Diabetes at the Osvaldo Cruz German Hospital located in São Paulo, Brazil. And the title of the talk is Mom's Randomized Controlled Trial, Adding Drugs to Bypass to Reduce Complication of Type 2 Diabetes. Please.
Thank you very much. Thanks to the audience to be here with us. I think, Carol, you exhausted all questions to Phil.
I saved all the difficult ones for you.
Oh, that's Dimitri. Those are my disclosures related to this presentation. And our target is to put diabetes and obesity under control. And I like the idea of obesity remission because I think we can get there with the combination of treatments. And we know that obesity management is the primary treatment for type 2 diabetes because the weight-centric approach is an upstream intervention, while the glucocentric approach only. So if you look at the EMPA-REG study, for example, their good outcomes were not related to glycemic control, but yet to microvascular complications, for example, in the EMPA-REG kidney. So this weight-centric approach treats what exactly the diabetologists want and need. They treat the macro and the microvascular complications. And let's not forget that the patients got obstructive sleep apnea, they have hypertension, NASH, and etc. So the weight-centric approach can put type 2 diabetes into remission and mainly can decrease the fatal and non-fatal cardiovascular events and the microvascular complications that it's the kidney disease. And let's not forget that although surgery is a very potent option for the treatment, if you look at the SOS trial in the first years had a decrease of 11 points of BMI. But if you look at the follow-up, we see that although it's still effective, obesity may recur. So we have a very potent option to treat. I don't like to say that surgery is a tool because semaglutide is not a tool, it's a treatment option. So we have a treatment option that its effects does not wane over time, but obesity is a chronic and progressive disease. So it may be more powerful than any intervention by themselves. If you look at the treatments for obesity, it's interesting to know that we have a Gaussian, a biological response to treatments. If you look here at the treatment on the right side of your screen, surgery represented by the gastric bypass and Roux-en-Y gastric bypass has more patients to the right of the screen, so more patients that will respond better to the intervention, while we have semaglutide 2.4 milligrams and tirzepatide 15 milligrams, again with a biological response, but they have less power inducing weight loss than surgery by itself. We collaborated, Carol and myself, with the SOREG database from Sweden, where they have 65,000 patients with a follow-up up to 10 years. And if you look at the left side of the screen, you see all the patients who underwent surgery. And patients with type 2 diabetes, even undergoing surgery, has a greater mortality than those who underwent surgery and didn't have diabetes. So there's something different, and there's something we need to do to improve the outcomes. So operated patients with uncontrolled type 2 diabetes have, although they were submitted to surgery, probably most of them the gastric bypass, they had a higher mortality at the first year post-op. And why not think on using pharmacotherapy in those patients in order to achieve better outcomes, decreasing cardiovascular mortality? This is the 13th randomized controlled trial. So Phil showed the 12th. This is the 13th randomized controlled trial. So it's the gastric bypass plus the medical treatment versus the best medical treatment. And the primary endpoint was the control of the renal disease. So we had 100 patients, 49 in the medical group, 15 in gastric bypass plus medications. All the patients had diabetes. All the patients had microalbuminuria. All the patients had BMIs from 30 to 35. It's the only study with 100% of patients with BMIs below 35, and all of them had early stage chronic disease, kidney disease. And again, this is the first study that used the very best and modern medical treatment. We used, besides metformin, insulin, glitazones, and all the medications that are listed there, we used GLP-1 receptor analogs. At that time, it was liraglutide and empagliflozin, SGLT2 inhibitors. In the best medical arm, we kept the ACE inhibitors and the ARBs. They have a proved kidney effect. We kept the statins, we kept metformin, and of course the multivitamins. The primary endpoint was UACR, urinary albumin-creatinine ratio below 30, and those are the secondary endpoints: chronic kidney disease remission, metabolic control, weight loss. Different from the other 12 randomized controlled trials where withdrawing medication was an endpoint. Even in Stampede, withdrawing medication was an endpoint. Our secondary endpoint was withdrawing medication or titrating down medication or up, whatever the patient needed. And we assessed neuropathy and quality of life. If you look at the dichotomous primary outcome, it was our primary outcome, UACR below or above 30, the results were surprising. At 2 years, the gastric bypass had significant effects over microalbuminuria. However, at 5 years, although there's a trend for the bypass plus the medical treatment to be better in achieving the primary endpoint, drugs worked and worked very well. So there was no statistical significance between best medical treatment and the gastric bypass plus the best medical treatment regarding urinary albumin to creatinine ratio below or above 30. If you look at UACR as a continuous variable, now we can see that patients submitted to the Roux-en-Y gastric bypass had a geometric mean of albuminuria levels greater than 45%, 46%. So we have more patients in the range of very low albuminuria, and this is a proxy for cardiovascular events and mortality. So surgery in a continuous variable was better than medication by itself. If you look at early stage chronic kidney disease, at 2 years in a JAMA Surgery publications, we saw superiority of surgery. However, at 5 years, again, drugs work and work very well when compared to surgery with Roux-en-Y gastric bypass plus medications. Regarding weight loss, only 22% of the patients in the best medical treatment, and we had most of patients reaching the highest dose of liraglutide, 3 milligrams. Only 22% achieved over 15% of total body weight loss, while 90% of the bypass patients reached over 15 total body weight loss. No patients under the medical treatment reached normal BMI. None of the patients reached remission of obesity, while 53% of patients submitted to the bypass reached remission of obesity, if we can call like that. Regarding glycemic control, surgery was better regarding glycemic control than the best medical treatment. Again, we can see here that the outcomes in the best medical treatment regarding albuminuria resolution and chronic kidney disease resolution were independent of glycemic control. If you look at the ADA target of A1Cs below 6.5, surgery had a significant advantage over the best medical treatment. Surgery has better quality of life regarding all the domains at 2 and 5 years, and it's very safe. We had one surgery complication. It was an anastomotic stricture managed by endoscopy. No serious hypoglycemia in both groups. What we call serious hypoglycemia is actually hypoglycemias that needed to be admitted to the hospital and treated. So we had no serious hypoglycemia in both groups, no malnutrition in this lower BMI range, and no excessive weight loss. Some of our internist colleagues were afraid of excessive weight loss in this BMI range. If you look at what we can learn from this is one recent paper on the use of semaglutide in patients with obesity only, with weight regain or insufficient weight loss. Although we don't have a clear definition of what's insufficient weight loss or what's weight regain, this is very interesting. In both operations, the adjunctive therapy with semaglutide promoted weight loss, augmenting weight loss on the operated patients. So, and in exact same proportion of patients without surgery. So semaglutide works. It's not a high level of scientific evidence, it's a retrospective review, but it's interesting to pay attention. This is Alex Mira's paper, the Gravitas, where they had 80 patients that were submitted to the bypass or sleeve gastrectomy with persistent or recurrent diabetes. Alex used liraglutide or placebo in the groups that patients should have at least 1 year after surgery, and the follow-up was 24 months. And it's clear that post-operative pharmacotherapy augments, potentializes surgical weight loss. And the curves with liraglutide, they're still going down. So we can see here that adding medications, it's really a very good strategy. This was published a couple of weeks ago. It's called the Berry Optimized study, where they took 18 men and 52 women, and the patients had at least 1 year of metabolic surgery, mostly sleeve gastrectomy in this cohort, with poor weight loss. They defined it as less than 20% of total body weight loss, and a suboptimal GLP-1 responses before surgery. So the intervention was 70 patients randomized, 57 analyzed, 31 with 3 milligrams of liraglutide with Saxenda, and 26 in the placebo. And the primary outcome was the change in the percentage of body weight from baseline to the end of this short period of 24 weeks. Again, nice results showing that a good decrease on weight in patients with liraglutide 3 milligrams, and the curve still goes down. So adjunctive pharmacotherapy is a very important option to treat those patients with weight regain or insufficient weight loss. And I think with the multi-receptor drugs, the 3G, for example, that carry the same weight loss as a gastric bypass, for example, at 68 weeks, I think we're closing the gap for the treatment of diabetes. So we need to work with drugs to achieve diabetes control, the decreased cardiovascular events, fatal and non-fatal, and put obesity into remission. I'm finishing, Carol. So I did an indirect comparison between our MOM study, the microvascular study that I just showed you, with the SURPASS-1 study, that's tirzepatide in people with obesity and type 2 diabetes. We know that people with diabetes and obesity lose less weight either in surgery or in the drugs. So look at the mean change of weight in the tirzepatide group is 11% at the maximum dose, and in our patients around 25%. So imagine if we do both together. Probably we're going to start doing a study with this, but probably we're going to achieve much better outcomes, merging both alternatives than surgery alone or medication alone. And this is a very nice slide that shows that 88% of our Roux-en-Y gastric bypass reached over 15% of total body weight loss versus 22% in patients in SURPASS-1 in patients with diabetes and obesity under tirzepatide. And I think that we need to change our mind. Look at this paper from our cardiology colleagues. What is the problem in adding medication to our patients with diabetes and obesity? They do that when they add antiplatelet drugs, statins, ACE inhibitors, beta blockers. Mortality in patients with a cardiac stent improved. So why not us joining forces with the modern medication? The cardiologists do this for the past 20 years. So I can see any problem joining efforts with the drugs. And I think that diabetes treatment needs to follow this path. First, the self-directed lifestyle changes to involve the patients in the bundle of care of diabetes, and then professionally directed lifestyle changes. We know that 2 out of 10 maybe benefit for this long term, then add medications and then surgery. But the best strategy is unifying surgery plus the best medical treatment. So this was a cake in the past, in the last Mexican Congress of Obesity. It's a cake. So what they did is the gastric bypass or whatever metabolic operation like the sleeve gastrectomy plus medication. I'm sure that still we have not compelling data, but I'm sure that joining forces will achieve the best outcomes for our patients. Thank you very much.
Please come to the microphone for any questions. So what is going to be the future now, Ricardo? Because now we're thinking about using surgery in a randomized control trial to show a cardiovascular mortality benefit. So how are we going to achieve that? Is it going to be surgery alone? Is it going to be surgery with drugs? You know, what's your best strategy to optimize surgery to show that it reduces heart attacks when we compare it against base medicine now?
I think the path to follow is surgery plus the best medical treatment versus the best medical treatment. So
And what medical treatment?
GLP-1 receptor analog, so semaglutide. So in 2 months, we're going to have the SELECT trial outcome. So, and they just announced in a press release, Novo Nordisk. So I think it's semaglutide plus a combination of other drugs if needed versus the bypass and drugs, GLP-1 receptor analogs when needed.
Okay. Question?
So Ricardo, in your evaluation of nephropathy, which you showed, the urinary albumin creatinine ratio, you showed more than 30 and less than 30. What was the upper limit, or what were the higher values? Because so many times we see, and Carol has done a lot of work on this also, that at times you just have a slight increase, which is a fluctuant range, and it need not actually correspond with a reduction of EGFR. So what were your ranges of?
Yeah, we selected patients with early stage kidney disease. So it's albuminuria over 30, but less than 300. So this is the definition of microalbuminuria.
Microalbuminuria.
Yes.
So you took only that range?
Oh yeah, only early stage kidney disease. We're now undergoing a trial with end stage kidney disease, with macroalbuminuria and impaired glomerular filtration rate, so it's stages 4A, 4B. Those are much more difficult patients than those ones. Those are with chronic kidney disease, but early stage.
So do you find that when the microalbumin is in some thousands, that you don't get a resolution of nephropathy? Because that's what we found with metabolic surgeries.
We have no data. I think we're going to produce the first randomized control trial within 2 years, hopefully.
Thank you.
Alex Mires?
So the combination of medicine and surgery clinically looks very interesting, but is it ever going to be cost effective?
If we are hopeful that the cost of the drugs will decrease over time, I think yes, this will be cost effective, because if we prove that we take patients out of dialysis, we decrease the fatal and non-fatal cardiovascular events, or the non-fatal that spends money from the healthcare systems, I think, yes, it will be cost effective if we balance, if we do the adjusted. In the meantime, it's not cost effective at all.
So what would you do? Who would you give it to?
If the patient can afford the drug, I would do it. I don't have any.
So you would give it to the rich. Is there a specific combination of factors apart from that in the patient characteristics that would suggest to you that the medication is more, the combination is more likely?
What we're doing, Alex, it's not science at all, but we've been doing for the past 2 years is in BMIs over 50, we are adding semaglutide from the 3rd month post-op. We don't wait plateauing, we don't wait regain, we just treat the patients. As the oncologists don't wait the metastasis after a mastectomy, they start with the radiotherapy or whatever early, we introduce the medication as early as possible. And we add the SGLT2 inhibitors as well, but at the third month and up to avoid ketoacidosis. So we are very aggressive with medications.
Thank you.
But Alex, while you are there, let me ask you the question, then let's throw it back to you. So who do you think we should be treating with these new medications in combination with surgery?
Yeah, so again, I have no data to support what I'm saying, but I would be guessing that we will have to choose those with established cardiovascular disease and established kidney disease as our first group of people to prioritize based on what indirect evidence from the medical literature. But I'm guessing. And the rich, that is the other group.
Carlos?
Thank you, Ricardo. For you and the panel, which are our options, drug options, to treat our bariatric metabolic patients? we talk a lot about GLP-1 agonists, but what more we have to give our patients, maybe cheaper, and to increase the results?
Well, I'll probably talk about it in my talk about this, but if you're looking for type 2 diabetes, and actually just as a balance to this, one way of doing this is giving cheap medications to everyone very early on. That's what diabetologists did about 20 years ago with Steno-2, and by just giving early on without waiting, and I'll challenge both Alex, who mentioned early on that we have to wait and see what the response is, and Ricardo, you also said let's, surgery plus medications if needed. What about giving everyone metformin, when it's safe to do so, everyone a statin, everyone aspirin or antiplatelet agents, when the diabetologists did that in Steno-2, they saved a lot of lives in a similar group to the group you studied in MOMS, Ricardo. So just a provocative answer.
What's your opinion?
Actually, I completely agree with you. I will. You use metformin, for instance, or whatever now the diabetologists are using when we are not able to afford, the most expensive drugs.
Yeah, the MOM study taught us to be aggressive with medications. We do not withdraw metformin. We keep metformin unless patients had any GI effect. We keep ACE inhibitors and ARBs with kidney disease. And in patients with severe obesity, we start GLP-1 receptor analogs as soon as possible. The GLP-1 receptor analogs are the spotlight today because they proved decreased cardiovascular mortality. So I think they're the most adequate medication to go with metformin.
Carlos, but before you go, because you did the Gateway study, one of the great randomized controlled trials for hypertension, but how thankful are your colleagues when you and Ricardo and others are now suggesting that we should be operating on sicker and sicker patients? You are now suggesting we should be operating on people with uncontrolled hypertension, with kidney disease, with heart disease. What is this realistically going to do to the very, very, very low mortality rates that we have? Because remember, the very low mortality rates we have is based on operating on people that is not that sick. So if we're going to operate on sicker patients, we're going to do more good things, but we will also increase our mortality rate. What do you think about that balance?
Yeah, my friend cardiologist is still afraid of surgery, as you show in the Medtronic Symposium. And I think we still have a lot of work to convince them that surgery is safe, although we probably will have more mortality rates in these very severe critical patients, but I think we will have a lot of work to do, but they still are afraid with surgery. And
But metabolic surgery in end-stage chronic kidney disease has the same mortality as patients who undergo and do not undergo surgery. So surgery does not increase mortality over the patients who already have end-stage kidney disease. So I think nephrologists, but cardiologists should be used to interventions. Nephrologists look at dialysis, 10% mortality per year, at least. They look at transplant. They look at graft rejection. So they are a little bit more comfortable with interventions than cardiologists, for example.
Yeah, I think they are comfortable, but they do, although they do a lot of minimal invasive procedures now, and maybe that's the point.
Okay, but how comfortable are you as surgeons to actually have higher mortality rates? Because it's a whole generation of surgeons that's grown up thinking that the mortality should be 1 in 1,000.
No, but currently, today, drugs probably will take care of the patients with BMIs of 35 and reflux, 35 and
I understand that.
So we need to be we need to teach our new generation that yes, you're going to get the hardest patients.
And you are comfortable with increasing your mortality rate?
Yeah, mainly because the other side, not doing nothing, mortality is 10 times greater.
I understand that.
But not very comfortable, I think. It's not always comfortable to have mortality.
Sure, another question, thank you.
Papes from Athens. So I have been doing bariatric and metabolic surgery for the last 20 years, and one of our basic sayings to our patients was if you do surgery, you will get rid of medication, or you will not be needing medication at least for the next 10, 15 years. And it was a very strong thing to say. I operated a man just a month ago. I was trying to persuade to be operated, obese. When he started having microalbuminemia, and he said, oh, I'm going to have a big problem with my kidneys. So yes, after 4 years, I decided for bariatric surgery. Now you are telling me and him that even if you don't get operated in long term, you will have the same level of microalbuminemia, whatever. So you will not benefit of anything. So are we talking now that metabolic surgery is under question? Is this what we are discussing here? Because if we are putting drugs earlier and earlier, okay, we know that metabolic surgery or bariatric surgery, whatever, will not last. It's not a solution for the next 20 years of the patient, that in 5 years, 10 years, we will have some problems. But if we now tell the patients that we will operate on you and we will start early with drugs or even before the operation, then what have we achieved all these years?
Actually, if you look at the SOS data, it's the largest follow-up. You see that patients, long-term, they regain weight, diabetes glycemic remissions gets smaller than 2-4 years post-op. So our pitch to the patients needs to be different. We need to add surgery plus the best medication available when needed to achieve the best outcomes, to avoid in 10, 20 years that a patient with an early stage chronic kidney disease is under dialysis. So there's no shame on telling the patient that you have two strategies that can work together. Think about oncology. Think about the slide I showed regarding the coronary stents. They're going to put a stent so the stent has no value. Of course, the stent saved his life. But if you keep antiplatelet treatment, if you keep statins, your mortality will decrease. And I can tell you that patients accept that and they're very happy to keep on medications, even insulin, if they understand that it's a combination of strategies for the best outcomes. So our mind needs to change. We offering a patient a definitive solution with surgery. For sure, at the mid to long term, some patients won't have the benefit compared to adding medications to the operation. So we need to change our minds, because all we want is the best outcomes, and not say that we did an operation this morning, tomorrow the patient is without insulin, as I used to do. I'm not saying that I changed my mind all of a sudden. Back in the first DSS in 2007, we were angry when internists said, well, you should titrate down insulin. No, I did a gastric bypass yesterday. I just withdraw 100 units of insulin because I saved lives. And this is bad for our patients, and even it's bad for our reputation, because 10 years later the patient comes back with weight regain and under dialysis. So we have to change our minds and work together as the oncologists do.
Thank you very much. Thank you very much. So we're now going to the final speaker, so Dimitri Prinaris from Bristol, who is going to talk to us about the BiPlus randomized controlled trial. So Dimitri did one of the first studies where he compared gastric banding with gastric bypass and showed that the group with the gastric banding arm had exactly the same hemoglobin A1Cs than the bypass, because the banding had more medications. So that was a shocking result at the time, but nonetheless, so Dimitri, tell us how you're going to shock us in the future.
So thank you. It's a very exciting session. I'll be talking to you about BiPlus, and I'll say straight away, I will not be showing you results of BiPlus because the study is ongoing, but I'll be talking to you about lessons learned from cancer surgery. And Ricardo had mentioned oncology. I'll drill more into this. And I'll take you back into you're training. Most of you surgeons or IHPs or physicians have done cancer surgery or looked after patients with cancer, worked in multidisciplinary teams looking after cancer. I work in North Bristol. This is a picture of the hospital on the one sunny day of the year. This is my disclosure of interest, and I work with a variety of organizations to deal with this complex disease. But perhaps most importantly, I am a surgeon and I have been a cancer surgeon. I was doing cancer surgery until 7 years ago. I spent a lot of days and sadly quite a few nights doing minimal invasive esophagectomy for cancer. I've done prophylactic gastrectomies for cancer, and I still diagnose on a weekly basis a large number of people with hepatobiliary or esophagogastric cancer. And I think the parallels are there, and I'll keep going back into that. So we're in Naples, so a lot of you know I have a Greek background, so it's the Greek philosophy versus the Roman philosophy, so I decided to stay away from that. And this is a French author, André Gide, got a Nobel Prize in 1947, and what he said is that everything has already been said, but we have to keep going back into this because we forget about it. And I think that's true about dealing with complex diseases. We know how to deal with the cancer. We accept the fact that we don't do randomized controlled trials of chemotherapy versus radiotherapy. We just do combinational treatments. We don't wait for a drug not to work to see exactly what it does. We start with, you look at breast cancer, we're giving mastectomy and plus minus auxiliary surgery, plus chemotherapy, plus radiotherapy, plus hormonal therapy. And we don't wait to see what the effect is. And I'll keep going back into that concept. So I think we have to do it just like the oncologists. They've been doing this for a long time. I think cardiology is also a good example. I think hypertension is a good example. But when we communicate that with our colleagues, when we communicate that with our patients, we have to use examples of diseases that people have been dealing with a very long time. And obesity, sadly, is no one of them. In fact, for a very long time, and still today, it's not considered a disease by many of our colleagues, but by big parts of society. So the first thing we need to do when we talk about combination or multimodal treatment, which is what we really have been talking all day, is what is the intention? We have to clarify that. It's different when we're doing neoadjuvant pharmacotherapy, so when we're trying to reduce weight, and that's weight loss, not necessarily weight loss maintenance, improve intraoperative access, reduce the perioperative risk, reduce that mortality, which is likely to go up when we operate on patients with higher complexity. What do we do about weight regain, which is rescue pharmacotherapy, just like we do in the cancer context when the patients experience a recurrence of the cancer? That's a different intention to what I think remains most elusive, and I think it has been highlighted today, which is adjuvant chemotherapy, getting the best result with combining modalities from the start. Not wait for something not to work, but do that very early on. And I'll be focusing more on that for the rest of my talk. The other aspect, and it has been mentioned before, but I think we have to highlight it again. When we do multimodal treatment, we have to be very specific about the quality of the interventions. So it makes no sense to do a surgery plus medications, but actually do not give the right medications. And if you look at oncology trials, the first thing you do if you're looking at a new agent that has been used in combining, for example, esophageal cancer, surgery, radiotherapy, and chemotherapy, if you're adding a new agent, you expect state-of-the-art surgery, you expect state-of-the-art chemotherapy, state-of-the-art radiotherapy, and we need to do the same. So if you're a physician and you're doing a trial, you have to aim for state-of-the-art surgery. And if you're a surgeon doing this trial, and of course we all work together, we would expect state-of-the-art medications. There's no point in using medications from 30 years ago. We need to be using state-of-the-art treatments to be able to compare really properly apples with apples. And we have to do the studies. So when we say that it makes sense to give some, let's say, semaglutide or a triple G factor together with a sleeve gastrectomy or a gastric bypass and expect a good outcome, is not the same as saying we've done the study and we've now seen the outcome. And those studies are not the sexiest studies. but they have to be done. And we have to start now so we can actually get the results and aid our decision making in the years to come. Now, having convinced you that we should do it just like the oncologist, I'm now going to tell you how we should be doing it just like the obesity experts. And if you saw all the studies today, the first group of patients to study is people with type 2 diabetes. If last night you discovered a molecule that is going to achieve 50% total body weight loss in a tablet, you'll be very happy. But the first group of patients you'll try it on will be people with type 2 diabetes. That's what the industry has done in pharmacotherapy. That's what surgeons have done. And you saw the previous studies, Stampede, MOMS. We focus on those patients. You learn from those. You see the weight loss outcomes in the post-hoc analysis, and then you can design a study on people without type 2 diabetes. And we saw this with semaglutide, with tirzepatide, etc. And that's exactly what we did. So BioPlus is a study on people with type 2 diabetes to prove the concept of adjuvant pharmacotherapy very early on, from the beginning, from intention, not waiting for something to not go well. So this is a randomized controlled trials of patients with type 2 diabetes. The protocol was already published. Ricardo Cohen, Alex Miras, Carl Rue, they're all involved in this study. I'm very grateful for that. And what we're doing is we are either giving a intensive goal-directed medical therapy together with a sleeve gastrectomy or a Roux-en-Y gastric bypass, or we do the standard of care, which in most hospitals is wait and see. And what we're chasing is exactly those RDF targets. So A1C that demonstrates control, blood pressure, systolic blood pressure, and lipids that are under control. And we treat those to target with whatever medications we have. And I mentioned earlier on in the discussion about STENO2, you can say that this is a STENO2 study in bariatric surgery, combining modalities. And those pharmacotherapy options are not expensive all the time. So you can achieve some of those with metformin, with lipids. It's just about giving those statins, giving that metformin. So we'll have an endpoint at 1 year, which is A1C, to prove that actually we can do that, and then at 5 years, where we are looking at all the RDF targets. So we have 32 patients already randomized. This is in University College Dublin and in North Bristol. As you would expect, about 70 patients that we've included. This study has been affected by the pandemic, but also a change in practice. I think that we will see fewer referrals, and Ricardo mentioned that earlier on, of people with type 2 diabetes and a lower BMI. We will be getting more and more patients without type 2 diabetes and higher BMI. So this will probably affect this study in some ways. So we excluded some patients. We now have 15 and 17 in each arm. We're already having patients appearing at follow-up. I'll be able to present some results in future. So I'll conclude by saying that we can learn from oncology, and I think we should use those examples more often than we do. And I think we need to do the studies, and we need to start now, and we need to adapt to those. And we have a new pharmacotherapy agent. We can design a new study. We can have adaptive designs. So we can have studies where we say best pharmacotherapy at the time. And if that changes, we can adapt into that. We've demonstrated that for the first time in a bariatric surgical trial with a bioband sleeve study that was presented early in this meeting. So I'll conclude here by acknowledging my colleagues in North Bristol, colleagues at University College Dublin, of course, Jessica Maddock and Therese Coleman, who are in the audience and participating in the study, and Alex and Ricardo, of course. Thank you very much.
Thank you. We have some time for questions, so please come to the microphone. So, Dimitri, you talked about, convincing, surgical colleagues that this is the right way to go. How hard is it to convince internal medicine doctors that it's the right thing to do to combine medicines with surgery?
So the quick answer is tough. The longer answer is that, and I think we have to also go back into the challenges, the background challenge of metabolic surgery. So convincing our colleagues that people with type 2 diabetes should have surgery has been difficult. And all we have to do is just remember that despite all these randomized controlled trials, despite all the years at IFSO meeting talking about the clear benefits of metabolic surgery, the number of people we operate on with type 2 diabetes globally has not changed. It's 20%. And I think that always surprised when I sort of give this figure back to my colleagues. They all think that we operate on people with type 2 diabetes. In fact, a lot of my physician colleagues did not believe that people with a BMI over 50, which is my average in my practice, do not have diabetes. And so I think that's the background challenge that we have to accept. And after we've done that, we can consider that it's a new concept. It's a new concept. And I think that we should capitalize on the fact that diabetologists in particular are very familiar with multimodal treatment outside the surgical context. So we're just adding just another intervention. And I think what we can do, and cardiology was mentioned as an example, is exactly that. They're very happy, our diabetology colleagues are very happy for their patients to get stents on top of the aspirin, on top of the clopidogrel, on top of the statin, on top of the metformin and the GLP-1 receptor agonist, and maybe some SGLT2 for good measure. So why can we not say we're adding a sleeve gastrectomy or a wide gastric bypass? I think we need to communicate that better.
Okay. And just going back to your example of cancer, you know, my understanding was it was really the cancer surgeons that was driving the combination therapy approach. You know, it wasn't the oncologists, you know, that was the main drivers. It was the surgeons that ran those trials. We spoke about the esophageal cancer and the work that John Reynolds and others did. But maybe just remind us about the history of how surgery moved to this multimodal approach. Because that wasn't the state of the art 20 years ago, right?
Well, so that's a great example. So what I do, this is my typical exam question. So if there are any British trainees, they will know that. So if you want to catch a GI surgeon, I always ask them, what is the most important study in esophageal cancer surgery in the last 30 years? And I bet you nobody says it's robotic surgery. Nobody says minimally invasive esophagectomy. It was actually the MAGIC trial where they gave chemotherapy and they revolutionized care. That study was driven in the UK, has a global impact. This is why most of our patients getting chemotherapy now, and actually outside this study context, most of those patients had actually gastric cancer. We now give it to people with esophageal cancer because the results were amazing. So surgeons can drive that. I don't think it's elective. I think we are duty bound to ask for that. And that's what I was alluding to earlier on, that if we're doing combinational therapy as surgeons, we have to demand good care. And I think we need to expect that from our physician colleagues. Again, in collaboration, that's really powerful. And that's how we will use those historical perspectives to change clinical care for people with obesity, with or without type 2 diabetes today.
I just wanted to add to Dimitri's answer to your question. I think the most important thing is that we should stop lying. We as surgeons were lying for many years that we cure diabetes. And the internists are still lying that they are dealing with their diabetic patients. Whenever I talk with my colleagues, we are collaborating, and I tell them, let's work together, he says, no, my patients? I am over them? I control 90% of them, and they don't control over 20. And we as surgeons have to accept that we're not curing diabetes, but we are fighting for remission or better control. So this is what we have to do.
Maybe final comment from you on that. That's a good way to end.
So Harry, that's an excellent comment. So I would just go into more detail in that, and I'll go back a little bit to the discussion about medications. So we have also been disingenuous by saying that surgery stops medications. That's factually incorrect, because all of our patients are getting multivitamin tablets. So we are prescribing medications, or we're doing something that needs lifelong tablet taking. There's no escape from that. So why is it so difficult to say, I'm going to do a bariatric operation, you can take some calcium, you can take some vitamin tablets, by the way, take the metformin and the statin as well. It's exactly the same. So I'll finish with that.
Well, listen, I want to thank all the speakers. I want to thank you as the audience for a great session. Thank you very much, and enjoy the rest of the conference.